Integro Patient Conference here in Glasgow. I hope you all had a nice break, had some coffee and potentially some medication.
Potentially coffee.
Up next this evening we have our panel on psychiatric health. On this panel we have Dr. David Howells of Cannabis Patient Cardiff, who I didn't introduce last time, another fantastic clinic here in the United Kingdom.
So I'm Dave Howells. I'm married to Sam, who you met earlier. We set up Cannabis Clinic Cardiff, and I've always known that Sam's benefited from cannabis, medical or otherwise. And so when she discovered that she was able to get a prescription, I felt duty-bound to prescribe for others. I was just so grateful that we would no longer have to hide and pretend that this wasn't a part of keeping ourselves as well as we could be. And from doing that alongside my work as an old age psychiatrist in the NHS, evenings and weekends, that grew into such a rewarding part of my life to be able to do that for patients and get the feedback that on a daily basis I was changing people's lives in a way that I certainly wasn't experiencing within the NHS. For the 20 years I was in mental health and the 15 years as an old age psychiatrist, despite having prescribed pretty much every psychiatric drug in the book and come along with benefits and side effects, and certainly cannabis, even though as an unlicensed and under-researched medication, just opened my eyes to a world whereby I could do professionally so much for patients that I couldn't do in the NHS, and left that over a year ago to just fully focus on this as a new exciting field of medicine, and that's why I'm here now.
Dave, we just heard the whole alphabet of illnesses, diseases, and disorders. How complex is the average patient that you see? Because it's not just anxiety, isn't it? There's always more.
I think the research coming out of the Drug Science Project 221 looks at 50% of people having a pain condition, 40% of people having an anxiety disorder, but also there's many more people who have both. Who have complex conditions with pain and anxiety and PTSD or ADHD, and so people on polypharmacies, people with other physical health conditions, all of which have to be taken into consideration. So there are some people who definitely need to have expert medical oversight of their condition, and not everyone is like that. Some people do have very pure illnesses and very little else wrong with them, but that is the minority. The people that I see may have comorbidities, and fortunately the medications we use for mental health are roughly the same as you would use for pain conditions and in roughly the same sorts of dosages. So people can have benefit from more than one thing, and that stems back to the evolutionarily primitive endocannabinoid system, which predates pretty much every other system in the human body. So the fact that it affects multiple systems at once to achieve that homeostasis, that balance, it should not be surprising to anyone. And the fact that when Dr. Sunny said that it's not taught in medical schools, and certainly was when I was there and probably isn't now, it's just scandalous. It's absolutely scandalous that we don't allow the people who are giving us treatment on a day-to-day basis in the NHS the knowledge and expertise in this, and there's a willful ignorance to remedy that. And so there's an awful lot to be done from within the medical profession, who tend to be quite a closed profession and tend to only listen to other people within that sphere. And so that's why having the Royal Colleges and NICE and the professional bodies on board is so vital.
Yeah, staying with you a little bit longer, in the previous session we talked about what would be the reasons to go from black market to actually go to a clinic. The complexity of the illness, is that also, I always think having a doctor's oversight versus self-medicating, there is a benefit in talking to somebody like you when you choose medication, isn't it?
I would say that yes, we are working as a team, the patient and the clinician, to come up with the correct sort of treatment for them. However, we won't know which that will be. It's different to everyone. There's a lot of talk about, this terpene and this genetics, etc. Simple fact is we don't know, and we have to hold our hands up and say we have ignorance in so many areas of this. Is it the terpene that gives the secret sauce? Is it minor cannabinoid? Is it some other element? So I hold my hands up. Well, admitting your ignorance is the first stage of knowledge, and so from that point we can build up, and that's where we are. And that's where I say I don't try and sell a particular treatment to a patient and say all the patients I have seen with your condition have benefited from this. Doesn't mean you will. You're being a human guinea pig. You're doing a research trial of one on yourself. And as long as you accept that, and we can do that in partnership, then fine. But at least we'll know the unknowns. We'll know that what we're getting is what it says on the tin. Whereas from an illegal market supply, you won't know necessarily what the genetic is. You won't know whether it's how it's been grown or produced, or whether it's been sprayed with anything, which I hear all the time these days. And I hold my hands up, yes, there's some excellent artisan producers, some maybe in Glasgow, some maybe in this room. I'm not disparaging you, but that's not the norm. The norm is the street weed, which people go to extraordinary lengths, facing criminality, sanctions, arrest, court, damage to personal, professional relationships, losing occupation. The list is endless and it's tragic.
Okay, thank you.
What's in your bag?
You have had adverse reactions to psychiatric medications. Is there possibly a link to that neurodivergent people have an adverse reaction to the alcohol?
The psychostimulants, the ADHD model is that you lack dopamine as an ADHD person, and that you behave in ways which stimulate you, that gives you that extra dopamine. So the stimulants are replacing that. And a lot of people find great benefits from it, but do get the side effects of insomnia and appetite suppression, which cannabis can help with. Some people don't tolerate the stimulants and have to think about other ways of coping, which cannabis does seem to be one of those methods. The research with cannabis really is very sparse. In fact, when I first started practicing, I wouldn't prescribe for people with ADHD. And it was just over time I was seeing more and more people who were telling me that, this really works. And I became convinced because of my clinical experience, not because of the academic literature.
Dave, can I ask you a slightly different question? Do you see difference between prescribing oils and prescribing flowers?
Just from a biological perspective, it is a completely different drug you're taking. If we just sort of focus on THC, you inhale THC, it goes in your bloodstream, around your body. That's THC working within seconds, if not minutes, lasting a couple of hours with a nice big peak in there. It has its effects. You take THC as an oil, and it needs to be absorbed first, so it depends on what you've got in your stomach. If you have fat in your stomach, it absorbs like 10 times greater. It goes into your bloodstream, straight to the liver, first-class metabolism, gets mostly converted into an active metabolite. That takes an hour or two, and then lasts about 6 hours. And so that's the best way I think of it. The next generation will come out with micro-emulsions, so that there'll be greater bioavailability, greater uptake into the body. I'm very interested in some of the sprays which are going to come out, which are alcohol-based, which you put under your tongue. The mucosa doesn't absorb oils very well. So putting THC into your tongue, you have to basically leave it there. The pastils are slightly better, but the oils, not a lot gets absorbed unless you sort of leave it there forever. In general, the big effects are within a couple of hours. So to me, that suggests it's more sort of absorbed through the gut rather than onto the tongue. The next generation of medications will have different administration methods, whether that would be through isolates or the biological compounds. Again, one of the advantages for industry is that if they adjust the biological components and patent the administration method, that is a way for them to get money. Industry is more likely to do that rather than start producing biological medications. Pierre, you're the godfather of pharmaceuticals, so I'm sure you have more knowledge on that than I do.
Yeah, there's a good point you bring up. I think we're looking at a couple of things. We're looking at inhalers, like with asthma inhalers. The other reason why I really like that is because it's for traditional non-trained doctors in cannabis. They're used to that. People are used to prescribing inhalers for asthma indications and everything else. So that makes it potentially a bit more that. The other thing we're looking at is patches, because that is a very interesting. There's a slow release. You just stick a patch on, keep it on there for 2 or 3 days. Easy to quite difficult to evaluate because it's not, I mean, Josephine mentioned clean. The reality is that both CBD and THC go very, very slowly through your skin, if at all. Developing patches are difficult, but I do believe there's a future in doing those things.
Which would be great. I mean, just the uptake of cannabis within the British National Formulary, the big book of drugs that doctors can prescribe, I think will have knock-on effects for stigma. Once we've got a range of things that doctors can prescribe in the NHS, I don't think that's going to be the biological therapies anytime soon.
So is it the case that the reason why NHS will not prescribe is because it is actual filler? Why not just accept that cannabis comes as a filler?
So if you look at how medicines get into the NHS,
Right.
you have NICE, so the National Institute of Clinical Health and Excellence. What the NHS will do, the NHS will look at NICE to do an assessment of that medicine. NICE have put together a whole system which fundamentally only works if you have a traditional randomized controlled clinical trial to compare that product with something that already exists. Randomized controlled trials would compare one active ingredient with another. One. So you can look at ibuprofen versus paracetamol. One-to-one comparison. A plant has, 180 different ingredients, THC, CBD in different ratios, terpenes, God knows what. And every strain is different. So to organize a trial to compare whatever flower with ibuprofen or opioids, statistically would be incredibly difficult to do. So you would have to do one single strain versus ibuprofen. And we all know one single strain very often is not the answer. If you have to do that in a clinical trial where patients have different medications, different times of the day and after, so that's going to be incredibly difficult to show to NICE that they can come up with. Even epidiolex didn't really
So do you
pass
think-
the test. So doing trials is very difficult, and it's going to be incredibly expensive. That's the other part, and you see that without making it too complicated. So GW have epidiolex as a licensed medicine.
Yeah.
They spent 300 million doing those trials. The result is that epidiolex costs £1 a month. What happens then? The NHS says, well, we can't afford £1 a month, so we still can't get it. We see there are more and more patients. Clinics are perfectly capable of dealing with the patient numbers. Once you get to 100,000, 200,000 patients, then the NHS cannot ignore anymore that there is a benefit of that.
Right.
And I fundamentally believe that that is the way forward. Just create this avalanche of patients that have a benefit. And then you will see doctors do things. You said it, and I think Sally said it. You got engaged, you got involved in cannabis because patients were asking about it. So the more you ask, the more doctors will start, maybe I should look into that.
Questions. Who's got their hands up?
Is there any mental health conditions that you cannot prescribe cannabis for? And is there any movement from Integro and the other clinics to be able to obtain cannabis without having medical condition with 2 prior treatments being offered? Because it seems like it's a last course only, people that have been self-medicating and managing their own conditions for various things, they can't access medical cannabis because they've not got a doctor's history of it.
The regulations are clear that as unlicensed medicines, they must be initiated by a specialist consultant on the GMC specialist register. So that's the initiation phase, and they have to be satisfied that you have tried other therapies. So that would typically be a licensed pharmaceutical, but in the case of mental health could also include psychological therapies. So those are boxes that you would expect people to have ticked. You can prescribe for any condition where you feel that there is a sufficient evidence base for prescription. The controversial case of schizophrenia would be typically an exclusion criteria for most people. I do know that there have been consultants in the UK who have prescribed for people with those conditions or psychosis, so it's not an absolute contraindication for some For myself, I would be very, very cautious about prescribing for someone with a history of psychosis, irrespective of whether or not someone had been using for a long time and not had adverse events. We are at a very immature phase within medical cannabis whereby there will be adverse events happening to people with prescriptions. Whether or not that's got anything to do with the medical cannabis is another matter, and that's going to hit the headlines at some point. So one of us doctors, Dr. Sunny, will be prescribing for someone who may get in a fatal car crash or involved in some big high-profile media event, and medical cannabis will be dragged into this. So that's a very real risk for our professional reputation. So it's not necessarily the actual biological risk of an adverse event, it's the public perception which will undoubtedly be seized upon by tabloids to then target this burgeoning field of medicine. So that's why I'm quite cautious, but in effect there are no absolute contraindications, it's just down to the initiating consultant.
Alright, very sorry guys, we do have to cut it there. Thank you all so very much for coming. I also want to thank all of our panellists for answering our questions and talking about their experiences so eloquently. We really do appreciate it, and we want to thank all of you for coming.